This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This is our roundup episode where we give quick summaries of the last 10 articles that we reviewed. How are you doing tonight, John?
I'm doing great. Another wonderful day of clinic. It's 9 o'clock. I'm ready to kind of hit this review.
I'm looking forward to it too, and we'll try not to take too long, although we always say that and then we just can't help ourselves. So, John, are you ready to kick it off with our article from episode 41?
Okay. Yeah, let me start off. It's episode 41, Vaping for Smoking Cessation. We covered the article Electronic Nicotine Delivery Systems for Smoking Cessation from the New England Journal of Medicine. And this was an overview of the Extends study. So the study overview, the Extends trial was an open-label, randomized controlled study conducted in Switzerland from July 2018 to June 2021, evaluating the efficacy and safety of e-cigarettes as an aid for smoking cessation alongside of standard of care. The study population was adults 18 plus that smoked at least 5 cigarettes per day for a year, and they wanted to quit. They excluded pregnant women and breastfeeding individuals and recent users of nicotine replacement. The study procedure was kind of interesting. They did a pre-screening that was conducted by a nurse navigator. They did a baseline visit where they randomly assigned participants to the intervention group, either e-cigarettes and counseling or control, which was counseling plus optional nicotine replacement therapy. They did data collection on demographics, smoking status, carbon monoxide levels, withdrawal symptoms, and adverse events. The primary outcomes was continuous smoking abstinence at 6 months, and they validated that biochemically with the carbon monoxide levels. Secondary outcomes were various measures of sustained abstinence. Results, so they basically screened 1,246 participants, 622 went into the intervention, 624 into the control. In terms of the primary outcome, abstinence was statistically higher in the intervention group that received e-cigarettes, 28.9% versus 16.3%, and that was an adjusted relative risk of 1.71. In terms of safety events were similar between both groups, with only kind of minor respiratory improvements noted compared to in the intervention group compared to the standard of care group. So people actually kind of had probably as mitigated through increased smoking cessation that they had better respiratory outcomes. So this article was really interesting because it really kind of concluded that e-cigarettes combined with standard of care do appear to be more effective for smoking cessation compared to standard of care alone, which is somewhat kind of practice changing, since I think a lot of us are kind of somewhat hesitant to recommend e-cigarette use in that manner.
Yeah, I think it was a really good article. It gives us a little bit of data to go with if we do want to recommend people use e-cigarettes, as a quit smoking technique. Great. Ready for the next one?
Yeah, let's do it.
All right, so episode 42 profiled an article called about the protective effect of buprenorphine. The article was called Quantifying a Potential Protective Effect of Buprenorphine on Fatality Risk During Acute Fentanyl Overdose, published 2024 in the Journal of Substance Use and Addiction Treatment. So for me, this article, I won't say it was practice changing, but it definitely was kind of perspective changing for me. So it's well established that patients who are prescribed buprenorphine have a lower risk of opioid overdose death. The buprenorphine helps patients with withdrawals and cravings from opioid use disorder, enables them to use fewer illicit opioids. And that's what I thought. I thought you're using fewer opioids, so you have less risk of overdose. But there's another way that buprenorphine protects against overdose death, and that's by physically blocking the mu opioid receptor and directly preventing the lethal effects of fentanyl. And I did know this theoretically, but I hadn't really, in my mind, conceived of buprenorphine protection that way. And this study set out to investigate in real-world patients if being on buprenorphine would be protective against fentanyl overdose. The way they set up this study was looking at patients who died of a fentanyl overdose, and they said, in patients who died of a fentanyl overdose, is there a difference in the fentanyl blood concentrations between those who also have buprenorphine in their systems and those who didn't? Basically, in those people who died, did it take a higher dose of fentanyl to kill them, to cause death, if they had also taken buprenorphine? That was their question. Study included 3,036 people in West Virginia who had died of an unintentional fentanyl overdose between 2011 and 2020. And they looked at the post-mortem fentanyl concentration in those people who did and who did not have buprenorphine in their bodies also at the time of death. There was a secondary outcome, which was fentanyl concentration in long versus short-term buprenorphine use, using the buprenorphine-norbuprenorphine ratio to assess that. And just for our audience, remember that buprenorphine has a very long elimination half-life. So if the metabolite norbuprenorphine is present, that indicates that some bup was taken at least 2 to 3 days prior to the test, and it wasn't just involved in the acute overdose. We thought this was a pretty good trial, good data set, large sample size of over 3,000 people who had died of fentanyl poisoning. Weakness, again, it was a retrospective cohort study, and we only have data on the people who died, but no information about people who survived. So the overall picture of buprenorphine's protective effect is a bit incomplete here. So that's how they set up the study. When you look at results, the median fentanyl concentration in the blood of people who died was 65% higher when buprenorphine was present compared to when it was absent. So for specific numbers, 0.028 versus 0.017 micrograms per milliliter with a p-value of less than 0.001. In a multivariate model where they adjusted for multiple compounding variables, there were statistically significant associations between the buprenorphine presence and increased fentanyl concentration, with a buprenorphine-norbuphine ratio of less than 1, indicating chronic use. So for people who had used it for more than 2 or 3 days, that was a protective effect. Obesity, being male, having alcohol, and having cardiovascular disease was statistically significantly associated with lower fentanyl concentrations, meaning they were not protective, they were harmful. And marijuana and history of substance use disorder were associated with statistically significant higher fentanyl concentrations, meaning that they were protective. So in conclusion, this article definitely changed my thinking about why being on buprenorphine is protective against overdose. It's not just because you use less fentanyl and thus are less likely to overdose. It's that it's harder to overdose if you have buprenorphine in your system, blocking mu opioid receptors. And so this has strengthened my resolve to really keep my patients in treatment if they're at risk for using illicit opiates. And using illicit drugs is a reason to get people onto buprenorphine, not a reason to stop treatment or kind of dismiss them from treatment. So what did you think of this article, John?
I think it's great. Kind of validates a practice that I think a lot of us already participate in, but definitely kind of shows how this is such a life-saving medication and how useful this is, even when you think it's maybe not effective.
Next one.
Episode 43, Alcohol Use Disorder Meds at Hospital Discharge. This is one of my favorite articles. It's outcomes after initiation of medications for alcohol use disorder at hospital discharge. It was from JAMA Network Open. And basically, this was a retrospective cohort study examining 6,794 Medicare patients with 9,834 alcohol-related hospitalizations in 2016, and it evaluated the impact of initiating medication-assisted treatment for alcohol use disorder at discharge on 30-day clinical outcomes. The study population was the 6,794 unique Medicare enrollees. They accounted for over 9,000 alcohol-related hospitalizations. Basically, it was inclusion of anyone admitted to acute care with alcohol use disorder, with medication for alcohol use disorder at discharge was kind of the intervention. So it was kind of anyone of this kind of very frequent flying population at many of our health institutions. They kind of excluded certain like programs like Medicare Advantage enrollees, people with contraindications for medications for alcohol use disorder, and prior medication for alcohol use disorder use. So the exposure was basically defined as a pharmacy claim for picking up naltrexone, acamprosate, or disulfiram within 2 days post-discharge. So it was prescribed, so it linked a hospital to pharmacy claim. Primary outcomes was a composite all-cause mortality or hospital return within 30 days. So it looked at mortality, kind of repeat hospitalization, but also a big driver, as I'll talk later on, is kind of repeat ED presentation. Secondary outcomes were individual metrics for mortality, hospital return, and outpatient follow-up. The validity of the study, I really like this study. It's a large retrospective cohort study of a large Medicare database. So it's not a true RCT. It was just kind of examining people that kind of received this intervention and didn't. I think it kind of really is kind of a very in vivo exposure of this medication. When you look at actually out of all these enrollees, only 2% actually received medications for alcohol use disorder, which I think reflects reality in our system, right? These are underutilized medications for a group of patients that kind of disproportionately utilize our healthcare system and need help. Very kind of surprisingly and very impressively, in terms of the primary outcome, which was this kind of composite score of mortality and return to evaluation, there was a 42% reduction in kind of this outcome if you received one of these medications within the 2 days of discharge. So that means that, like, 42% decrease in kind of chance of mortality, hospital return, or ED representation. And I will say that when you kind of broke those categories down, while they were all significant, the big driver was decreased ED visit representation. So it decreases your kind of unnecessarily emergency department utilization. So I think that kind of the takeaway I get from this kind of large cohort study is that kind of initiating medications for alcohol use disorder at discharge for patients with alcohol use disorder is an underutilized intervention that has a lot of effect. And we should probably be considering these to decrease our patients kind of representing and also helping them while they're kind of a captive audience.
Yeah, I agree this was a great study, and I really felt like the results were even more impressive than I would have anticipated. Like, the benefit of starting these medications was a lot more than I thought it would be, and it's just interesting that so few people get them at all. So, but yeah, it was a great study.
Yeah, I think like we're doing a project at our hospital through the EMR that's going to flag these patients with kind of consideration to start this. If I can ever get the EMR build to be complete, but it's going to get there.
All right, you ready for the next one? Episode 44 was titled Cannabis and Cardiovascular Outcomes. And we talked about this paper that was called The Association of Cannabis Use with Cardiovascular Outcomes Among U.S. Adults. And amazingly, it was published in the Journal of the American Heart Association. Not amazing because it didn't deserve to be published, but they're not known for publishing addiction medicine studies. So I was happy to see it. We all know that cannabis use is increasing, and cannabis is becoming more relevant as a modifiable cardiovascular disease risk factor. And now there's actually more people who use cannabis daily or near daily than use alcohol daily or near daily. And so we really do need to know what is the effect of cannabis on the cardiovascular system, given how many people are using it. The basic clinical question is, what is the association between cannabis use and cardiovascular outcomes? This is a population-based cross-sectional study done at a single point in time. They used this survey called the Behavioral Risk Factor Surveillance Survey. It had 434,000 plus people in it, and it's a cross-sectional telephone survey performed by the CDC. It has survey data from 2016 to 2020 and includes all adults who answered the question about cannabis. So there are some questions about cannabis in the survey. If you answered them, you were in this study. They looked at data about cannabis use, cardiovascular disease, and other cardiovascular risk factors, and they tried to tease out the overlap between cannabis and tobacco use, which has been a big sort of confounder in other studies of cannabis and cardiovascular disease. It was a pretty simple survey. And keep in mind, all this data is self-reported. So people were basically asked about, did they use cannabis daily or non-daily or not at all? And did they have heart disease in a few different ways? In terms of the people in this study, about 4% were daily cannabis users, about 7% used it but not daily, and almost 90% didn't use cannabis at all. So that's kind of the population in this study. So it's not a population that's heavily using cannabis. I did think this was a valid trial. They did the best they could with this single point in time data. They did really good statistical analyses, sensitivity analyses, subgroup analyses, a lot of analyses. It was representative of the American population because that's how the study group is designed. And I liked, as I said, sorting out the overlap between cannabis and tobacco. Also, I just think very clinically relevant. There were some significant limitations, though. One, self reported data, subject to recall bias and dishonesty. Um, the groups were different at baseline, as you might imagine. People who use cannabis daily were different in many areas from people who didn't use cannabis at all. And in this study, they tried to adjust for these differences. And I'm sure there were some unmeasured confounders leading to differences in the three groups beyond cannabis, but the groups were different at baseline. Finally, the biggest problem is that it's just a point in time study, like one time right now. And so it's not able to assess causation. It's like, do you have heart disease right now? And do you use cannabis right now? Um, in fact, it only asks about cannabis in the last 30 days, but it asks about cardiovascular disease anytime in the past. So there's even a possibility for reverse causality, meaning you got cardiovascular disease first that may have preceded the cannabis use. And maybe you were so stressed out by your cardiovascular disease, you started using cannabis, not the other way around. Also, the effects of cannabis on the cardiovascular system are probably reversible, just like tobacco. And past cannabis use is not reported, only current cannabis use. So, ideally, you would want to know the patterns of cannabis use just prior to the cardiac event that the person had. But that was not assessed directly in the study. And finally, there's a low incidence of cardiovascular disease because people were pretty young. So those were the limitations because, again, it's just a survey, but it was still a pretty good study. So, in terms of the results, basically, 30-day past cannabis use is associated with adverse cardiovascular outcomes, with heavier use associated with higher odds of adverse outcome. Most of the difference in the composite outcome was actually driven by stroke rather than heart attacks. And so the primary composite outcome is the prevalence of MI, stroke, or coronary heart disease. And the adjusted odds ratio for the association of daily cannabis use and coronary heart disease was 1.6. For MI, it was 1.25. So bigger means there's a bigger difference. And for stroke, it was 1.42. And for the composite outcome of all three together, the odds ratio was 1.28. There was also a clear dose response effect. So the more cannabis that was used, the higher the risk of cardiovascular disease. Um, and the lower the use, the lower the risk of cardiovascular disease. It was also shown that this effect existed for people who never smoked tobacco, which is very relevant because tobacco and cannabis go together. Um, and bottom line, among people who don't smoke tobacco, daily cannabis use was associated with MIs and strokes, but not with coronary heart disease. Another thing that was interesting about the non-tobacco smokers is that the confidence interval for the cardiovascular risk for cannabis-only users and tobacco-only users overlap, suggesting with at least with this survey instrument, it's possible that tobacco and cannabis provide equivalent cardiovascular risk, which is very interesting to me. So, how is this study going to help me? In this study, there was a strong association between cannabis use, especially daily, and stroke among the general population, and people at high risk for cardiovascular disease among younger people, among people who've never smoked. Um, Among all these groups, there was a strong association. So, with this data, I'm going to add cannabis counseling into my counseling for people with heart disease, hypertension, coronary artery disease, congestive heart failure. I always ask about tobacco, I ask about alcohol, and now I'm gonna ask about cannabis because it's a pretty, likely cardiovascular risk factor. And in this study, even, stronger than alcohol, and I'll be counseling against its use. So, to me, this was a pretty important study. What do you think, John? What did you think of this?
Yeah, I think this is something that kind of increasingly I'm kind of counseling on, like the harmful effects of. For a combination, right? It's like it's probably not a healthy habit for many of us, but also kind of with kind of medicinal marijuana and recreational marijuana, certainly it's kind of being used quite more frequently. And I think that there's a this is an area where I think there's a level of risk that's probably higher than what the average population is kind of.
Well, right, there's so much marketing about how natural and safe and wonderful it is and how it's a cure-all that the information about how it causes heart disease is getting lost a little bit in the marketing.
They just want something natural, doc.
All right, you go next.
All right. 45, urine drug screens and treatment retention. This is an article entitled The Association of Random and Observed Drug Screens with Long-Term Retention in Opioid Treatment Programs from Drug and Alcohol Dependence in 2024. It was a cross-sectional analysis of 150 methadone OTPs using data from the National Drug Abuse Treatment System Survey from 2016 to 2017, and it had about an 86.5% response rates amongst those OTPs. For eligibility, it included OTPs that provided methadone and actually participated in UDSs and also the survey. Exposure was OTP categorization, which is based upon how often they utilized it, which was kind of the threshold cutoff of 90% of clients. Primary outcomes were retention and treatment for at least 1 year. Secondary outcomes examined UDS practices and clinic characteristics with their associations related to retention to treatment. They used this fractional regression modeling to kind of validate these associations with one another. I like this because it was a valid study. It was from the NIH in terms of its funding. It had a nice cross-sectional design. It was a pretty large sample selection, 150 out of the total 657 possible programs. There is always potential for bias with survey data, especially when it comes to clinic characteristics and kind of how they view their clients and their relationships. These are really kind of proxy measures of clinic attitude. So I think that, not to kind of take with a grain of salt, but sometimes people say very nice things and maybe especially a leader at the organization, but it might not truly reflect that clinic's characteristics and feeling towards treatment or recovery. In terms of the results, as we said, 150 OTPs, they had a median client count of 310 per program. They were mostly private, for-profit programs, and they had a lot of variation actually in UDS practices. Clinic philosophy had a high focus on patient-centered care. So validity, the trial was funded by the NIH. It was a cross-sectional design, so relatively well done. It was a significant sample size, 150 out of a total of 657 programs participated, although there's definitely potential for participation bias and self-reporting bias. Like we talked about before, a lot of this is survey data. So like they're kind of talking about clinic attitudes based upon kind of a self-reported proxy measure from supervisors of the clinic. So that might not be what people actually received. In terms of the results, clinic characteristics included 150 OTPs, a median client count of 310. They were mostly private for-profit opioid treatment programs, and they definitely had kind of quite variable practices in terms of their UDSs. Interestingly, clinics that had a high focus on patient-centered care and drug abstinence monitoring were often cited as kind of like key measures for kind of retention and UDS utilization. And when you looked at retention specifically, there was higher retention in opioid treatment programs with low UDS usage, and the presence of a discharge policy positively influenced treatment outcomes, which was actually kind of the most interesting thing I kind of took away from this trial. So conclusion, the study highlights that OTPs with kind of lower rates of urine drug screening practices or UPT testing may achieve better results in terms of patient retention and methadone treatment. I think another kind of secondary take-home point that was incidental is that discharge policies really do play a critical role in enhancing retention and kind of suggest that a more supportive and less punitive approach to UDS policies may benefit treatment retention for our patients. What do you think of that kind of, Sonya?
I mean, it was a good article. It's a bit of a different setting than what we work in, methadone OTP compared to our own outpatient buprenorphine clinics. But it drives home the point that the urine drug screens are really it's just unclear. I think we both have sort of thought some this year about what's the point of all these urine drug screens. And this kind of supports that our traditional thought that they're a vital tool is maybe a little bit misguided.
Yeah, I think like Family Medicine 101 and, I'm different is they talk about like, you order a test, what are you doing with that information? And I do think that like, you want to monitor that people are being actually taking the medication. That's probably the most compelling reason to kind of assess for monitoring. But I think otherwise, I mean, are you going to discharge a person that's still using opioids from treatment for opioid use? I mean, do you discharge a diabetic from, you know, Ozempic or semaglutide if their A1C still stinks? I mean, it just doesn't kind of make sense. So I've kind of questioned how I use these over the years, and I don't like using them as a punitive,
Right.
uh, like marker, right? That's not what it's meant to be. I'm not your foe. I'm your doctor.
It's not a gotcha test where we're trying to prove you're doing something so we can punish you.
I actually the biggest takeaway I actually took from that was the presence of the discharge policy, how that had such a powerful mitigation on retention
Mhm.
in terms of kind of usage. And I've thought about this. I think we were just talking offline about actually maybe typing up an official like policy regarding like what discharge would look like if you do discharge someone and having someone like look at it and sign it, similar to what we do with our controlled substance agreements to kind of keep people retained in treatment longer.
Well, right, and I think if you're clear on what you need from people and it's not too onerous, yeah, it can avoid conflict if people know what you need from them. You know what's their part of the agreement. All right, ready for the next article? All right, 46. This one is definitely practice changing for me, although the practice espoused in this article is not FDA approved, so been a little difficult. But This was titled Smoking Cessation After Initial Treatment Failure with Varenicline or Nicotine Replacement, a randomized clinical trial, published in JAMA 2024. And so this was a great paper because, of course, people try on average 7, 7+ times to quit before they're successful. And I've never seen a paper before describing what you should do with people after an unsuccessful quit attempt. We just keep trying the same things. So this paper was really cool. Now, at this point in the US, 11.5% of the population are current smokers, and 60% of current smokers will die from a smoking related illness. So, the highest mortality of any addictive substance that we work with. 70% of people who smoke want to quit. 55% have made a serious quit attempt. And however, only 7.5 of those quit attempts succeed uh, at any given time. And only about 4.7% of people who are trying to quit received evidence-based therapy to assist them in that quit attempt. And so people are not using the medications that we know help, and they're trying over and over again. And there's just minimal research on best practices for treatment of smoking and helping with a quit attempt after an initial failed attempt. So that's the background. The overall goal of this study was to determine the best subsequent strategy after a failed quit attempt with either varenicline or combined nicotine replacement therapy. That was like a patch plus additional gum. It was double blind, placebo controlled, a sequential, multiple assignment randomized trial, all the adjectives, where people were randomized to receive 6 weeks of either varenicline or combined nicotine replacement. After 6 weeks, if you were still smoking, you got re-randomized to continue the same treatment, switch to the other treatment, so switch from varenicline to nicotine or vice versa, or increase your medication to a higher dose for 6 additional weeks. And those higher doses were varenicline 3 milligrams a day, where the normal dose is 2, or nicotine patch 42 milligrams a day, so 2 of the 21 milligram patches. This study included 490 adult smokers who were seeking treatment at a Texas tobacco treatment clinic connected to MD Anderson. And they were smoking an average of 1 pack per day for a mean amount of time of 28 years. So really long-term smokers. We talked about the intervention. So either you got varenicline, standard dose 2 milligrams per day, or nicotine, 21 milligram patch plus 2 milligram lozenges PRN for 6 weeks. And then if you were able to quit, you just continued the therapy for 6 more weeks to kind of bring it home. If you hadn't quit, you increased your medication to varenicline 3 milligrams a day or nicotine 42 milligram patch plus lozenges, or you just switched to the other medicine. And they also got counseling every week. And they were comparing the standard of care, which is to get your varenicline or your nicotine at standard doses. And if you hadn't quit, just to continue it for 6 weeks. That was considered the standard protocol. And these other protocols where you switched or got the higher dose were considered the intervention. The outcome was self-reported and carbon monoxide confirmed 7-day tobacco abstinence at 12 weeks. So had you actually quit smoking. Secondary outcomes were continuous abstinence at 30 days and then abstinence at 6 months. Did the effect last? And it was conducted over 12 weeks. And they did look at some investigational results as far out as 6 months. We thought this was a valid trial. Its strengths were that it was randomized, placebo-controlled, double-blind, pretty big, close to 500 people. Results were very relevant, and we liked the statistical analysis that they did. A few weaknesses, it was pretty short term, and even though they had 500 patients, in the end, there were 6 experimental groups, so there was only a small number of people in each group. Also, these high doses of nicotine and varenicline are technically off-label, so insurance might not cover them. And like any smoking cessation attempt, a large number of patients did not return for re-randomization. They were assigned to continue their initial treatment because they never came back, but who knows if they really did. Um, and then after re-randomization, a large percent of those people were also lost to follow-up. So, a lot of people kind of gave up on the study midway through. Finally, they didn't evaluate varenicline plus nicotine, which is actually the most effective treatment for smoking cessation that we know about, and it wasn't really included in this study. And I would have liked to have one arm with that. Just, let's just add more arms. The results, basically, bottom line, for people who smoked but did not achieve abstinence after treatment with varenicline, increasing the dose enhanced abstinence compared to continuing. Um, People who were initially treated with nicotine and didn't quit smoking Increasing the dose or switching to varenicline both helped with abstinence, and you could use those as viable rescue strategies. So the one strategy that didn't work was if you were on varenicline, it didn't help to switch it to nicotine. It helped to give you the higher dose of varenicline. To me, the most interesting numbers in all these different subgroups were the people who switched to high dose varenicline or high dose nicotine, because those are that's not something I've used before. So for patients who got nicotine replacement and did not manage to quit, staying on the same dose allowed 8% more people to quit, but switching to higher dose, 42 milligram patch, or switching to varenicline allowed 14% of people to quit, compared to 8% of people who just stayed on the same thing. So it just gave you a little bit more people, a little higher quit rate. And people who didn't quit after 6 weeks of varenicline, if they were switched to nicotine, nobody else quit. That did not help. If they stayed on the varenicline, 3% more people quit smoking. And if they were given the high dose varenicline, a whopping 20% more people quit smoking on that 3 milligrams a day. So that dose was unexpectedly effective compared to the 2 milligrams a day. I think this article will definitely help me in patient care. Um, when using varenicline, I could increase the dose. I could stay on the initial dose. The number needed to treat is about to achieve abstinence at 12 weeks is about 5. So you have to, for people who couldn't quit smoking on varenicline, if you switch 5 of them to the higher dose, 1 will be able to quit smoking in the next 6 weeks. So that's pretty good compared to some of our other interventions. So basically, if patients have not been successful after 6 weeks of trying nicotine or varenicline, I'm going to offer these higher doses, and I'll reassure patients that the side effects are pretty minimal, reversible, and I would probably choose varenicline preferentially if the patient didn't have a preference. What do you think, John? Have you been able to try this yet on anybody?
I have tried it since this article. I think this is kind of practice changer. And it worked for a period of time, as these often do, but it was more effective than the standard dosing. And I think with smoking cessation, smoking is just probably the absolute worst thing you could do for your health. I can't think of a worse product, right? So I think that kind of it makes the biggest impact in someone's overall health if you can get them to quit smoking. There's limited options. So I think that kind of retrialing things you've tried before, even if it's been ineffective in the past, and then off-label attempts like this are all very effective as something in your tool chest to try to get some people to quit smoking.
Yeah, I haven't. I tried to get the high dose varenicline approved for one patient. It wasn't approved by their insurance, but I have used the higher dose nicotine. And that's also reassuring because the nicotine products come with all these warnings that you'll like die of a arrhythmia or something if you like smoke one cigarette while wearing a patch. And I'm like, you could just slap on 2 patches. Um, and apparently it was safe in this study. So that's made me more confident about using higher dose nicotine as well. And telling people to keep the patch on, even if they relapse on cigarettes, just to keep the patch on to help you with your quit attempt rather than taking it off.
Yeah, my favorite new statistic is I'm taking the HIV medicine certification exam, and one of the practice questions was comparing life expectancy decline of someone with HIV to a smoker, since it's a very common comorbid condition. And you learn the most from the questions you get wrong. And it said that apparently the right answer was that kind of if you get a diagnosis of HIV in this day and age, on average, it's kind of a little under 2 years less life expectancy you obtain. However, if you smoke, it's about 25 years reduced life expectancy. And sometimes I tell that to patients, and that's very appalling to them and a motivator for change.
Yeah, yeah. I mean, anything we can do, as I said earlier, it's the most deadly of all the addictive substances that we work with is tobacco,
And you buy it at the gas station.
right next to the kratom.
Number 47, injectable versus sublingual buprenorphine for fentanyl use. And this was extended release injection versus sublingual buprenorphine for opioid use disorder with fentanyl use. It was a post hoc analysis of a randomized control clinical trial. And this was from JAMA Network Open. I think this is one of our more popular or downloaded episodes. Is that still the case, Sonya? You're the stats person.
Yeah, people loved this episode.
Yeah, so this is a post hoc analysis of a phase 3 randomized, double blind, active controlled study involving 428 participants with moderate to severe opioid use disorder across 35 U.S. outpatient clinic sites from December 2015 to November 2016. Inclusion was adults aged 18 to 65 seeking involuntary treatment for opioid use disorder. It excluded people with recent pharmacotherapy, significant non-opioid substance use disorders, and chronic pain requiring opioids. Outcomes were UDS results, self-reported illicit drug use, withdrawal scales, including CALS, SOS, the VAS, and adverse events. Basically, a little bit about the trial, how it was done. It was really kind of well done. So they had a screening period for 3 weeks where they screened for eligibility, followed by phase one of the trial, which was weeks 1 to 12. Participants in withdrawal received buprenorphine, naloxone, and they were randomized to either buprenorphine, naloxone, or subcutaneous buprenorphine. In phase two, which is weeks 13 to 24, they continued treatment, transitioning to monthly subcutaneous injections. And then they had a follow up 4 week period where they were transitioned to standard treatment with monitoring of ongoing outcomes. The study was funded by industry, so Braeburn Incorporated. So, not unlike any kind of drug trial, it was industry funded. They did have a role in study design, but not in data collection. It was a strong study design with subjective and objective outcomes. It was kind of somewhat limited by the 2016 kind of opioid use market. So, kind of a little bit kind of pre-fentanyl emergent or kind of like around the time of that emergent. In terms of results, 428 participants, with 123 of them showing baseline fentanyl use. They had similar demographics, so kind of very similar groups between the ones with and without fentanyl use at baseline. Both groups actually used comparable buprenorphine dosing. Retention to treatment was similar in terms of completion rates across the different buprenorphine treatment subgroups. In terms of safety outcome, there was really no difference in kind of sublingual or subcutaneous buprenorphine, with the exception of kind of local site reaction was clearly higher in the sublingual group or the subcutaneous group. In terms of the biggest kind of outcome, there was a very statistically significant difference in terms of any opioid use. So patients receiving subcutaneous buprenorphine showed more favorable outcomes compared to the sublingual buprenorphine and naloxone combination, particularly in the fentanyl positive subgroup with 24.7 versus 34.6% having kind of positive urine drug screens. And that was statistically significant. P was 0.009. So basically kind of a relatively large reduction in whether or not patients were having abnormal UDSs with the subcutaneous formulation. Not a great patient-centric outcome, but kind of very promising. The study overall does suggest that the subcutaneous buprenorphine may provide better outcomes in managing opioid use disorder, particularly in the fentanyl era and patients that are using fentanyl at the time of initiation of treatment. What did you think about the article, Sonya?
I mean, I thought it was really good. I'm all about the injectable buprenorphine. It's one of my things I've been really promoting and using and trying to share with patients. So, no, I thought it was a good article.
Yeah, I'm not gonna lie. Like I've said before, I'm gonna own where I was wrong here. The cost of this, I was kind of drinking the haterade when this kind of first emerged to the market, but it really is different. And I think the data shows this. And I'm a convert. I'm a big believer in this product for the right person.
Well, right. And I mean, I'm never going to tell a patient they have to use it. You know, it's the same active ingredient as the sublingual, but I just feel there's real benefits. And I really think anyone who prescribes buprenorphine should offer these injectables because it offers a lot of benefit for people, especially people who are struggling.
Yeah, I think that I agree with you. I think the one exception is, I mean, I do have patients that I've have both diversion and opioid use disorder. And I feel like it sometimes is a nice kind of product for that I'll kind of strongly recommend that.
Right. Well, sure. All right. Number 48. This episode was called Semaglutide and Alcohol Use Disorder. And the article was titled Association of Semaglutide with Incidence and Recurrence of Alcohol Use Disorder in a Real World Population, published in Nature Communication, another sort of unique journal. Not our typical addiction medicine journal. So, John, us in primary care, we love the GLP-1 agonists. Everybody loves them. 13% of Americans, or 1 in 8, have tried one of these medications. And currently, about 4% of Americans are actually taking them right now. There's been some preliminary data in people and in animals that the GLP-1 receptor agonists are helpful for reducing alcohol consumption. And this study tackled the association between semaglutide and alcohol use disorder in a really interesting and unique way. It was a nationwide multi-center retrospective cohort study, including almost 700,000 patients, and it was an EMR database study. So they used, data extracted from the electronic medical records, and they assessed the association of semaglutide with the incidence of alcohol use disorder diagnosis in people with obesity compared to people taking other weight loss medications. So these are people trying to lose weight using medications and comparing semaglutide people to people taking other weight loss medicines. They also looked at the subgroup of people with type 2 diabetes, both with and without obesity, as well as some subgroups divided by age, by sex, by race, and even a small group of patients who had a prior diagnosis of alcohol use disorder to see if semaglutide reduced the rate of recurrence. So these patients were being seen at large academic medical centers over the US in all 50 states. The inclusion criteria was obesity, no prior history of alcohol use disorder, and prescribed semaglutide or some other anti obesity medication for the first time. They also looked at two other groups, which were people with obesity and pre existing alcohol use disorder, and people with obesity who were prescribed semaglutide for diabetes, which they determined as it being prior to the FDA approval for its sort of weight loss indication. And you were excluded from the trial only if you had a history of bariatric surgery. They compared the semaglutide prescription to other weight loss medications, and they included naltrexone, topiramate, bupropion, orlistat, and phentermine. And you might notice that many of those medications also are used to treat alcohol use disorder, especially naltrexone, topiramate. So, outcomes: the development or recurrence of alcohol use disorder, as documented by the electronic health record diagnosis code. That was the primary outcome. And participants were followed for 12 months from the index event. Some of the earliest enrollees were followed up to 3 years, so not super long term. Um, I thought this was a very good retrospective trial. It was large, had over 80,000 patients in it, and had good follow up. But again, retrospective, observational, and there's a strong risk of unmeasured confounders, strong risk of self selection, and some concerns about reverse causality. Also, the outcome was the presence of the diagnosis code for alcohol use disorder, which is a little different than what we usually look at. I mean, we'll assume that it's a good surrogate marker for harms caused by alcohol, but it doesn't really give us data on alcohol use or alcohol related harms. I mean, it's possible that the diagnosis code appeared because patients were being seen at the doctor more frequently because of the visits required to take the semaglutide or something like that. Like, it doesn't concretely tell us how much alcohol was consumed or what the harms were. But overall, we thought it was a valid trial. The results were pretty good. So, compared to a non GLP-1 receptor agonist medication, semaglutide was associated with a significantly lower risk of incident alcohol use disorder diagnosis. So, 0.37% with semaglutide, 0.73% with the other weight loss meds. That gives us a hazard ratio of 0.5. And this was consistent across age, subgroups, gender, race. Significantly lower risks were observed in patients with type 2 diabetes and patients without type 2 diabetes. And when they compared it to naltrexone or topiramate, because those are also used to treat alcohol use disorder, semaglutide was associated with a significantly lower risk of alcohol use disorder diagnosis, so 0.35 versus 0.78 with a hazard ratio of 0.44, so even bigger difference. And that was also consistent across gender, age, and race subgroups, and with or without diabetes. So basically, semaglutide was associated with less alcohol use disorder diagnosis. In patients who already had alcohol use disorder, so this gets into the subgroup where maybe semaglutide is treating alcohol use disorder, compared to the non semaglutide anti obesity medicines, semaglutide was associated with significantly lower risk of recurrent alcohol use disorder diagnosis. So 22% recurred with semaglutide, 43% with the other medications. So a lot more people had recurrence if they weren't on semaglutide. The hazard ratio was 0.44. And again, consistent in all subgroups. Even when you compared it specifically just to naltrexone or topiramate, the semaglutide was associated with a significantly lower risk of incident alcohol use disorder. So 21.5% versus 59.9%. Again, consistent in all subgroups. So will this article help me in patient care? I mean, I don't think it's ready for prime time as a treatment for alcohol use disorder. That hasn't really been studied yet, but this drug, of course, is all over the news. It seems to help against, use of alcohol, opioids, tobacco, all kinds of cravings, and my patients really like it. My patients definitely wanna take semaglutide for obesity, and there is overlap between obesity and alcohol use disorder. Semaglutide is well tolerated. Um, so if I have a patient who could benefit from semaglutide and also wants to cut down on drinking, I definitely would recommend this. I'd say this might also help. However, it's very expensive. It's not always covered by insurance. Um, but I'm happy to tell my patients they might get reduced alcohol use, as a happy side effect if they're gonna take it for either diabetes or obesity. Um, and hopefully in the future, it will be approved for treatment of addiction as well. What do you think, John? Have you ever prescribed semaglutide for alcohol use disorder?
I haven't, but I've had some patients with alcohol use disorder on it for another indication. And like anecdotally, it's interesting. Before this was a thing, I've had people tell me it does mitigate their drinking. I think that this is a nice, promising future area here, right? I think it's a nice medication that a lot of people are getting comfort with. And it seems like it might be a great way of harm reduction in the right person.
Yeah. I'm really interested to see where it goes.
It's the new statin.
It's the new statin, everybody's on it.
Yeah. So number 49, this is naltrexone and bupropion for methamphetamine use disorder. So it's the article's entitled "An Extended Observation of Reduced Methamphetamine Use with Combined Naltrexone plus Bupropion in the ADAPT-2 Trial." It's from Addiction 2024. So this was a secondary analysis of the ADAPT-2 trial, which involved 403 participants to evaluate changes in methamphetamine use from urine drug screens during week 7 to 12 and post-treatment weeks 13 to 16. So this is a follow-up after the first kind of report out on this trial. The original trial was a 12-week double-blind randomized placebo-controlled study across 8 NIDA sites from May 2017 to July 2019. The intervention was that participants received either extended-release naltrexone, 380 milligrams, or placebo, along with weekly oral bupropion, with a dosage range of 150 to 400 milligrams, or placebo. It included adults aged 18 to 65 with moderate to severe methamphetamine use disorder and recent methamphetamine use. It excluded individuals in treatment or intending to use medical opioids. The primary outcomes were changes in methamphetamine use based on urine drug screens, and that was measured twice weekly by urine drug screen samples. In terms of validity, it was a NIDA, an Outcomeries funded trial, so there's potential research or conflict in terms of the funding. The specific participant group really limits generalizability because it was really only patients with methamphetamine use disorder. And I think the majority of us seeing this group, it often involves polysubstance use. Also, they do kind of mention that methamphetamine use kind of recovery tends to be a long, gradual process. So kind of a trial this short probably didn't do it justice. It probably underrepresented true effect of treatment. In terms of the results, in terms of the naltrexone and the bupropion, stage 1 showed an 18.4% increase in methamphetamine negative urine drug screens, which was statistically significant, and all combined stages showed a 27.1% increase in methamphetamine negative urine drug screens. So it seemed to be more effective than placebo. When you look at the placebo group, stage 1 had a 7% increase, which was statistically significant, and all combined stages also had an 11.4% increase. And this kind of goes back to the reflection that time is also kind of a significant marker of improvement for methamphetamine use, independent of treatment. In terms of the naltrexone and bupropion compared to kind of the placebo group, there was a substantially significant what they call difference in difference between the two groups of 15.8%, meaning that when you kind of like took out the time variable, treatment with this protocol resulted in a 15.8% improvement of methamphetamine negative urine drug screens, and that was very statistically significant, p 0.006. I really like this trial because it highlights a potential treatment target for this condition, which is really common and something we currently really struggle with. So in the future, I kind of will consider this for the right patient, or at least offer it if I don't have contraindications to naltrexone being probably the biggest limiter of generalizability.
Yeah, I thought it was a really good study. It's just hard because, most people come to me for buprenorphine, and so naltrexone's kinda off the table. So I need something that doesn't involve naltrexone for my patients who use methamphetamine, but also require buprenorphine.
It's an interesting group. I gotta find the niche.
Right. Well, I mean, there's tons of people who use methamphetamine, but I think because our medications are so much less effective, they're less likely to come to the doctor,
Yeah.
you know? There's gotta be some contingency management group out there you can find.
Yeah, it's out there. One of my friends has partnered up with someone. I mean, the problem with it is he had access to that, and then kind of funding is cyclical, dries up. So he has it, then doesn't have it, then has it. It's kind of hard to treat a group in continuity when you don't always have the resource available.
Right, exactly. All right, we're down to our last two. Anyone who's counting will realize that we already did 9 articles and now we have 2 left, because episode 50 profiled multiple articles. So I'm gonna do one, John's gonna do one on kratom, and then that will be it for the evening. So, for anyone who listened to our kratom episodes, we did them in collaboration with Dr. Casey Grover from Addiction Medicine Made Easy. So if you're listening, hi, Dr. Grover. My article was called Prevalence of Kratom Use Disorder Among Kratom Consumers. And this was a study that tried to characterize what kratom use disorder might be. So many consumers reported benefits to kratom, which is an herbal product, of a botanical product, the leaf of a tree that has both opioid and stimulant effects. But as use increases, and it's reported that anywhere from less than 1% to about 6% of the population has used kratom, a certain subset of patients find that their use is uncontrollable, and they develop basically a substance use disorder. So the question asked in this article is, could uncontrollable kratom use meet these DSM-5 criteria for substance use disorder? And what is the prevalence of kratom use disorder as defined by these DSM-5 criteria among kratom consumers? This was a survey study. 2,061 adults who were current kratom users completed an online anonymous survey, and they were recruited from multiple online communities, both pro and anti kratom. They were asked about kratom consumption, adverse effects, comorbidities, and components of the DSM 5 substance use disorder diagnosis. I thought the authors did a really good job with the data that they had, and this was a unique data set on an emerging problem without much previous data. But there were some serious limitations inherent in any kind of single point in time study. This was an anonymous survey. There's no objective data, no guarantee of truthfulness of the answers. And there's definitely some selection bias. Many people recruited would have had a favorable attitude towards kratom because they're using it. They're participating in some online kratom related group. They're engaged with the product in some way. And, if you're a current kratom consumer, you're less likely to be experiencing negative side effects because if you did, you'd probably stop it or maybe be more likely to stop it. Those who have adverse effects most likely are not using the product anymore and thus would not end up in this survey. So just a little bit of selection bias. The results, first thing that was interesting to me in this paper was patients' reasons for using kratom. 62.2% were using it to treat long-term pain issues and symptoms. 52% were using it because they felt crappy in general and just wanted something to feel better day to day. 51% just said it was safer than other drugs they could use. 40 to 50% said to boost energy, treat anxiety, depression, and a bunch of other reasons, but those were the main ones. The next set of results is about whether or not respondents experience the DSM-5 symptoms of kratom use disorder. I mean, there's no kratom use disorder in the DSM-5, but substance use disorder. The majority of the symptoms that participants experienced had to do with tolerance, withdrawal, and uncontrollable use. But other than that, very few people experienced adverse effects from the kratom itself. About 5% said they had continued to use it despite it causing harm. But most of the issue was just that it was habit forming, escalating use, and kind of out of control use. Um, so, of all the people who use kratom, 25% of habitual consumers meet criteria for what would be kratom use disorder. So, that's the main statistic. 25% of users develop a substance use disorder. 31% had tolerance, 22% had withdrawal, 17% had cravings, 15% had increased use, 9% had inability to cut down. And those who did have defined kratom use disorder, 65% it was mild. So most people had mild kratom use disorder. 20% had moderate and 14% had severe use disorder. The final fact that I thought was interesting was that there was a big overlap between kratom use and a history of substance use disorder, and between kratom use disorder and a history of opioid and alcohol use disorder. So 11% of the people in the sample were receiving treatment for a substance use disorder as well. So pretty big overlap there. In conclusion, I can tell patients that 25% of habitual kratom consumers develop kratom use disorder, although most of it's mild and most of it just has to do with physiologic dependence, so tolerance, withdrawal, cravings, using more than desired. But 25% is still pretty high. I definitely will counsel patients it's addictive. They need to be cautious about escalating use. It just gives me more information about this product as I move forward trying to help people who might be struggling with it.
Yeah, it's interesting. I feel like ever since we had this podcast, I only had a couple people come to me with kratom use disorder, but in the past like 2 weeks since we did that podcast, I've had 3 patients that are like former patients that are like very remote, and they wanted to talk to me about something personal. And this was it on 3 occasions in the past 2 weeks. I was very surprised by that. It leads me to believe it's more common than I think, and I'm probably missing it a lot.
I think it's really exploding, I don't know in use, but in publicity. Um, I had another physician call me on Friday, I guess, or whatever day it is, Monday, and say, "Have you ever heard of this thing called kratom?" Some patient had approached him and asked if he would help with getting off kratom. So maybe there's just more publicity about the dangers, and patients are realizing they can approach doctors for buprenorphine to help them with kratom use disorder. Not in the DSM-5 yet, but perhaps soon. Ready for our last article?
So this is long-term buprenorphine treatment from kratom use disorder. It's a case series from substance abuse. So kind of follow up with Sonya's article, like what do you do once someone does have kratom use disorder? This is a case series that evaluated 28 adults with kratom use disorder treated with buprenorphine across various U.S. clinics. Case selection, it was participants age 18 plus who identified kratom as their primary substance. The ages ranged in this study typically between 24 and 53, so kind of like younger adults to middle age. Data collection, this was analyzed EMR records for variables like kratom use duration, dosing, outpatient frequency, urine drug testing results for the derivative of kratom, the metabolite. You know, I really love this because I think this is just a bunch of docs that were just kind of treating people and want to share with everyone like what their experience was with using this kind of off label for this kind of disease to be that we're talking about. So I thought it was really cool they did that. And I just loved it. It was sort of like we just kind of hung out and had a conversation. The treatment protocol, they treated it very similar to what they would do for opioid use disorder at home induction with buprenorphine. Like I said before, very valid case theories, no funding, no conflicts of interest. I mean, God love them. The authors reported the fact that they were salaried physicians with a healthcare institution. Like that was a conflict of interest. They had a small sample size and very kind of potential for biases were limited. I mean, these were selected by the authors in their clinic practice, though certainly it wasn't kind of a randomized trial. It was based upon their clinical gestalt. There was kind of a lack of control groups and, also a lack of kind of data regarding concurrent conditions, but I don't think that was really what the scope of this article was meant to be. In terms of results, we talked about the average age was 36 of these participants or patients. The average kratom dose was 92 grams per day. Most patients stabilized on 12 to 16 milligrams of buprenorphine. And they looked at kind of like how do people respond to this? The overwhelming majority of patients had significant withdrawal relief immediately with the buprenorphine. 71.4% continued treatment over the first 11 months, with 69% showing negative urine drug testing results for any opioids. There was a substantial portion that did restart using kratom at different parts during the trial, just shy of 1/3, 32%. So kind of like I take away from this that like, while not a randomized controlled trial, and like we said before, really not even a DSM-5 or 6 disease yet, the case series does give some evidence that we can be using buprenorphine off-label. And I would say in my clinical experience, this is very appropriate because many of these patients have experience with that medication for opioid use disorder. So something that I think we can add to our toolbox moving forward as we see more of this.
Well, right. It's just kind of it's a little bit validating of something that a lot of us have been kind of winging it about. So I'm really glad they went ahead and published their clinical experience. Case series first, randomized controlled trial next.
Well, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.